You are sitting in a velvet-upholstered chair in a London physician's office in 1889, your hands trembling beneath your gloves. The room smells of carbolic acid and lavender oil. Gas lamps flicker against mahogany paneling lined with leather-bound medical texts whose titles you cannot quite read. You have come here because you cannot sleep, because your hands shake during afternoon tea, because last week at a dinner party you felt a suffocating pressure in your chest that made you flee the room. 3 doctors have already examined you. All 3 pronounce the same diagnosis with the same grim certainty: hysteria. And now Dr. Edmund Hartwell is explaining, in measured clinical tones, that he will need to examine you internally, that he will apply therapeutic massage to your pelvic region until you experience what he calls a hysterical paroxysm. You do not understand what this means, but you are desperate for relief. If you're fascinated by these moments when educated people were spectacularly, systematically wrong, leave a like and subscribe. I'd love to know where in the world you're watching from. Comment your location below. There's something extraordinary about our global community coming together to explore these dark corners of medical history. What you're about to witness is how an entire medical profession spent nearly a century giving millions of women orgasms while insisting, with absolute sincerity, that female sexuality did not exist. This isn't a story about a few rogue practitioners or fringe medicine. This is mainstream Victorian and Edwardian medical practice, documented in prestigious journals, taught in elite medical schools, performed by the most respected physicians in Europe and America. For 70 years, the treatment of hysteria through pelvic massage and later mechanical vibration was as routine as prescribing aspirin. The physicians who performed these treatments published detailed clinical papers describing their techniques. The patients returned week after week, sometimes for decades. The devices used became household appliances advertised in the Sears Roebuck catalog. And through it all, nobody involved seemed to understand what was actually happening. The story begins not in Victorian London, but in ancient Egypt and Greece, where physicians first theorized about the mysterious affliction that seemed to strike women with such frequency and variety. Hippocrates, the foundational figure of Western medicine, observed women suffering from anxiety, seizures, and what we would now recognize as panic attacks. His explanation would shape medical thinking for the next 2,000 years. The uterus was wandering through the female body. The Greek word hystera meant womb, and Hippocrates believed that when a woman remained unmarried or childless, her uterus grew restless. It would detach from its proper position and migrate upward, pressing against the lungs and heart, causing breathlessness and palpitations. It would lodge against the brain, producing madness and seizures. The organ, denied its natural purpose, became a kind of internal rebel. Plato extended this theory into something even stranger. He described the uterus not merely as an organ, but as an independent creature dwelling within the female body, possessed of its own desires and frustrations. When these desires went unfulfilled, the uterus would rage, and the woman would suffer the consequences of this internal conflict. The prescribed cure seemed obvious: marriage, sexual intercourse, pregnancy. Satisfy the womb's reproductive drive and the symptoms would vanish. By the Renaissance, anatomical knowledge had advanced enough that physicians could see the uterus did not actually move. Dissections revealed it was anchored in place by ligaments and blood vessels. There was no mechanism by which it could travel through the body cavity. One might expect this discovery to have dismantled the entire theory of hysteria. Instead, the diagnosis simply evolved. If the wandering womb theory was disproven, then something else about the female reproductive system must be causing the disturbance. The symptoms remained too widespread, too consistently reported across different populations, to be dismissed entirely. The diagnosis of hysteria persisted, now unmoored from any specific anatomical theory but still firmly attached to the notion that women's bodies were fundamentally unstable. Victorian medical textbooks devoted extensive chapters to the subject. Dr. Thomas Sydenham, writing in 1666, estimated that hysteria was the second most common ailment after fever, affecting approximately 1 in 4 women. By the 19th century, that estimate had grown even larger. Some physicians believed that 3/4 of all women suffered from some degree of hysteria during their lives. These weren't marginal medical opinions. These were mainstream diagnostic frameworks taught at Oxford, Cambridge, Edinburgh, Harvard, and Johns Hopkins. Medical students learned that the female constitution was organized primarily around reproductive capacity, that the uterus exerted a profound influence over every other system in the female body, that women were more delicate, more nervous, more prone to emotional collapse than men. The entire edifice of Victorian medical education rested on the assumption that women were biologically different, not just in their reproductive organs, but in their fundamental capacity for rationality and stability. By 1880, hysteria treatment had become one of the most profitable specialties in American and European medicine. In New York City alone, at least 24 physicians advertised themselves as specialists in female nervous disorders. Their waiting rooms were filled with women, appointment books scheduled months in advance. Dr. Horatio Taylor's Manhattan practice employed 3 assistant physicians solely to manage the volume of hysteria patients. His clinic saw an estimated 300 women per week. Similar establishments operated in Boston, Philadelphia, Chicago, London, Paris, and Berlin. The economics were compelling. A single hysteria treatment session cost between $2 and $5 in 1890s currency, roughly equivalent to $150 today. Women typically required twice-weekly treatments continuing for months or years. A physician specializing in hysteria could earn more than a general practitioner, a surgeon, or even many hospital administrators. The diagnosis itself had become infinitely elastic, capable of absorbing almost any complaint a woman might present. Insomnia was hysteria. Irritability was hysteria. Anxiety was hysteria. Loss of appetite was hysteria. Muscle tension was hysteria. Shortness of breath was hysteria. The condition could manifest through dozens of symptoms, which meant that almost any woman experiencing distress could receive the diagnosis. Medical journals published extensive symptom checklists. A woman needed to exhibit only 3 or 4 from a list of 40 to qualify for treatment. The diagnostic net was cast so wide that it captured a vast proportion of the female population. Dr. George Beard, one of the most prominent neurologists of the era, wrote that hysteria affected women of the better classes more severely than working-class women, because refined constitutions were more sensitive to nervous strain. This convenient theory meant that wealthy women who could afford regular treatment were considered most at risk. The middle and upper classes eagerly embraced the diagnosis. Having hysteria signified refinement, sensitivity, a delicate constitution unsuited to the coarseness of modern industrial life. It became almost fashionable to be under treatment for nervous exhaustion. They could not look away from the opportunity this represented. Physicians opened specialized clinics. Medical device manufacturers developed increasingly sophisticated equipment. Pharmaceutical companies marketed nerve tonics and sedatives specifically for hysterical women. The entire medical industrial complex organized itself around this diagnosis and its treatment. In 1895, it was estimated that American physicians earned $18 million annually from hysteria-related treatments. That figure represents approximately $450 million in modern currency. This was not fringe medicine. This was a central pillar of the medical economy. The treatment followed rigid protocols designed to maintain an atmosphere of clinical detachment. When a woman arrived for her appointment, she was led to a private examination room and instructed to remove her clothing from the waist down while keeping her upper body and face covered with a sheet. This arrangement served a dual purpose, preserving modesty while allowing both physician and patient to maintain psychological distance from what was about to occur. The examination table was positioned so that the physician approached from an angle that minimized eye contact. Some offices installed screens that allowed the physician to work without seeing the patient's face at all. The physician would begin by warming scented oil between his palms. Lavender was most common, though rose and violet oils were also popular. He would apply the oil to the patient's external genitalia using broad, circular motions. Gradually, the movements would become more focused, more deliberate, concentrating on what Victorian anatomy texts vaguely referred to as the sensitive areas. Many medical textbooks of the period contained no accurate anatomical drawing of the clitoris. Some omitted it entirely. Others labeled it incorrectly or described it as a vestigial organ with no known function. Physicians were literally manipulating an organ whose purpose their medical education had never explained. The treatment typically required between 20 minutes and an hour of continuous manual stimulation. Dr. Russell Thal, writing in the Boston Medical and Surgical Journal in 1903, complained extensively about the physical demands this placed on practitioners. His hands cramped. His wrists ached. The repetitive motion caused inflammation and chronic pain. He described the procedure as among the most tedious and exhausting in all of medicine, comparable to prolonged surgical operations. What he was complaining about, though he did not know it, was the difficulty of manually stimulating dozens of women to orgasm each week. The physicians documented everything with clinical precision. Dr. Samuel Gross's patient records from 1887 describe in meticulous detail what occurred during these sessions. The patient's respiration would accelerate. Her skin would flush. Her muscles would begin to contract rhythmically. Vaginal secretions would increase noticeably. Then came what the records invariably described as the crisis or paroxysm: violent muscular contractions, arching of the back, involuntary vocalizations, followed by a period of deep relaxation and reported relief from symptoms. These are textbook descriptions of female orgasm. Dr. Gross performed this treatment on hundreds of women over a 20-year career and never once recognized what he was inducing. The protocols extended beyond the physician's office. Wealthy women could arrange for house calls, though this required a nurse to be present for propriety. But the most fashionable option was the hydrotherapy resort. Bath in England, Baden-Baden in Germany, and Saratoga Springs in New York became destinations for women seeking water cure treatments for hysteria. These establishments featured specialized equipment: chairs with cutout seats positioned beneath powerful jets of pressurized water. The jets would be directed at the patient's pelvic region for 15 to 30 minutes. The French called this la douche pelvienne. Advertisements for these resorts promised complete restoration of feminine vitality through scientifically advanced hydrotherapy techniques. What was the experience like for the women undergoing these treatments? They inhabited a strange psychological space where something undeniably pleasurable was occurring, but could not be acknowledged as such. To admit pleasure would be to admit sexual feeling, which would mark them as unrespectable, possibly depraved. The culture had taught them that decent women felt no sexual desire. A woman who experienced physical pleasure from sexual contact was, by definition, immoral. Yet here was a physician, an authority figure, inducing exactly such sensations while insisting this was medical therapy. The cognitive dissonance must have been profound. The breakthrough came in 1883 when Dr. Joseph Mortimer Granville, a London physician, patented the first electromechanical vibrator. Granville's hands were failing him. Years of performing pelvic massage had caused severe arthritis and chronic pain. He approached the problem as an engineering challenge: how to achieve the same therapeutic result with less physical strain on the practitioner. His invention, called the percuteur, used an electromagnetic coil to produce rapid vibrations that could be delivered through various attachments. Initially, Granville insisted his device was intended for treating male muscular disorders, but physicians working with female patients immediately recognized its application. The efficiency gains were extraordinary. What had required 30 to 60 minutes of exhausting manual labor could now be accomplished in 10 to 15 minutes with a mechanical device. The vibrator didn't tire, it didn't cramp, It could maintain consistent intensity and rhythm. For the medical profession, this was a labor-saving innovation comparable to the introduction of the stethoscope or the hypodermic syringe. By 1900, vibrators were being manufactured by dozens of companies competing for the medical market. The Weiss Company's 1906 catalog offered more than 20 models ranging from small handheld units to large floor-standing machines with multiple attachments. The Chattanooga vibrator advertised that it could relieve hysteria symptoms in under 10 minutes. The White Cross electric vibrator promised to deliver the very essence of vitality to patients. These advertisements appeared in medical journals alongside advertisements for surgical instruments and diagnostic equipment. Vibrators were medical technology, as legitimate and respectable as any other tool in the physician's office. Then something remarkable happened. The devices escaped from medical control and entered the consumer market. By 1902, Hamilton Beach had introduced a home model that could be purchased through mail order for just $5. The Sears Roebuck catalog began featuring vibrators in 1908, describing them as useful and satisfactory for home service. These were not hidden in discreet medical supply sections. They appeared alongside sewing machines, toasters, and other household appliances. By 1910, the vibrator had become the fifth most common electrical device in American homes, more widespread than electric irons or vacuum cleaners. The advertisements maintained a careful fiction. They emphasized general health benefits, improved circulation, restored vitality, relief from nervous tension. A typical advertisement from 1910 showed a woman applying a vibrator to her neck and face with text promising that vibration is life itself, the secret of health and beauty discovered through modern electrical science. The images never showed the devices being used below the waist, yet the implications were clear enough for women to understand while maintaining plausible deniability for the manufacturers. They could not look away from the commercial opportunity this represented. The devices sold by the thousands, then by the tens of thousands. Women purchased them with their husband's knowledge and often their husband's approval, because the vibrator was a legitimate medical device prescribed by reputable physicians. Some women owned multiple models for different applications. The devices became common enough that they appeared as background details in family photographs, sitting openly on dressing tables or bedroom furniture, too ordinary to seem scandalous. The system that had sustained itself for nearly a century collapsed with shocking suddenness in the 1920s. The catalyst was not scientific enlightenment or medical reform. It was pornography. As motion picture technology evolved, underground stag films began circulating in private screenings and men's clubs. These illegal, explicitly sexual films showed people engaged in various sexual acts. And some of these films featured women using vibrators for obvious sexual purposes. When the vibrator first appeared in pornography, its true nature could no longer be denied. A device once marketed as a respectable medical instrument, advertised in family magazines, was suddenly associated with explicit sexuality. The illusion that women had no sexual desires and that doctors were treating an illness rather than inducing pleasure collapsed almost overnight. Within 5 years, vibrators disappeared from medical practice entirely. By 1925, the Sears catalog had dropped all vibrator advertisements, and medical journals quietly stopped mentioning them. Physicians who had built entire practices around treating female hysteria moved into other specialties. The hysteria diagnosis itself began to fade, replaced by emerging psychological terms like anxiety neurosis and conversion disorder. This transformation revealed something profound. Hysteria treatment had never been grounded in science but in collective denial. The medical profession, culture, and patients all maintained a fiction that sexual pleasure was impossible for women, and that doctors were performing purely therapeutic work. When that illusion shattered, the entire system crumbled. For the women who had received these treatments, the sudden disappearance must have been devastating. Many had structured their weeks around appointments that brought real physical relief and emotional calm. Diaries and letters from the late 19th century show women describing their treatments with careful understatement. One woman wrote in 1892 that her sessions restored her spirits and that she anticipated them with inexplicable eagerness. Another praised her doctor's method for its remarkable improvement in her mood and energy. They may not have had the language to name what was happening, but they understood its importance. Medical records offer more evidence. Dr. Edmund Hartwell's patient logs, preserved from 1888 to 1905, record 437 women receiving regular hysteria therapy, some for over a decade. One woman, Mrs. Adelaide Whitmore, visited every Thursday for 14 years. The notes describe her symptoms improving and her commitment to treatment, yet never once acknowledge what those paroxysms truly were. When historians uncovered these records, they were stunned. How could educated doctors perform such treatments for decades without recognizing their sexual nature? The answer lies in collective blindness. Photographs from a 1915 medical convention show male physicians seriously examining new vibrator models, unaware or unwilling to admit what they represented. The blindness was cultural, not intellectual. These were Harvard and Vienna-trained physicians, yet they worked within a system that erased female sexuality from textbooks, medical training, and professional discourse. This history reveals how knowledge bends to cultural consensus. Medicine exists not only in the realm of science but also within the limits of what society allows people to see. Victorian doctors were not villains. They were products of a worldview that denied women's sexual autonomy. Today, echoes of that blindness remain. Women's pain is still dismissed. Their symptoms are often labeled psychological. The vibrator that once treated hysteria now sits in museums, a symbol of both repression and revelation. For 70 years, women experienced genuine sexual pleasure under the guise of medical care, while society insisted such a thing was impossible. The evidence had always been there. It simply took a scandal to make people finally see it.